All right, I'm going to attempt to record Chapter 8. We were going to use an older recording, but for some reason it will not load correctly on D2L. So I'm probably not going to cover all of Chapter 8 in this recording. We'll cover some of it tomorrow, but we'll see how much we get through. I really do want you guys prepared. I know y'all have a test tomorrow, but I really do need you to be prepared for our class, because we're not just going to sit there, and I'm not going to just stand in front of you and lecture the whole time. So let's begin. So let's talk about some obstetric procedures, and some of these we've already talked about, but I just want to re-emphasize that you do need to know these and understand them. So amnio infusion. This procedure involves inserting fluid of either warm saline or lactated ringers, LR, into the uterus. The fluid is inserted through an intrauterine pressure catheter during labor. Of course, this can only be done after the rupture of membranes, or called ROM. Okay. Indications for use are the following here on the slide. We've talked about some of these, oligohydramnios. We've talked about cord compression. And so you do need to understand what the indications are for. It is typically a one-time bolus of fluid over an hour, or it can be a continuous infusion. It must continue, as a nurse, your responsibility is to continue to monitor both mom and baby very closely. And I don't mean just look at them. I'm talking about their vital signs. I'm talking about fetal heart rate, any accelerations, decelerations, and so forth. This is a very messy procedure, so keeping mom as clean and dry, changing out pads and towels often is very important. You also need to document the time of the procedure, the solution that is used, any color change in the solution or in the discharge from mom, how much is infused, and any odor that is noticed. Now, for those that do not know what meconium stained amniotic fluid is, meconium is the first stool of the newborn. Unfortunately, sometimes due to either the stress of labor or a hypoxic episode during the pregnancy or labor, the baby may have their first bowel movement inside of mom, and it's called meconium stain. We don't want this to happen, and there's no way to prevent it necessarily. So that's one reason, after checking fetal heart rate, after rupture of membranes, we always look at the color and note that color, because this is going to play a part of how we care for that newborn when it's born. Amniotomy, you all should know what that is. This can be spontaneous, or it can be artificial. Artificial means that it's been done by the physician. Again, fetal heart rate is #1 priority. It is a sterile procedure with sterile gloves, a sterile amni hook. The amniotomy itself actually can stimulate prostaglandin secretion. If you remember back, we've already learned how prostaglandin can actually help stimulate contractions. But before this procedure is done, of course, we want to get a baseline of the fetal heart rate. Okay, what is the baseline? What is the heart rate doing during the procedure, and definitely afterwards? And we want to listen to the heart rate for 1 full minute. Some complications, of course, we've talked about these as well. Prolapse of the umbilical cord, infection because that protective lining of the bag is gone. Okay, so for every vaginal exam or any instrumentation that is placed in the vagina or into the uterus can introduce infection into the uterine cavity. Even abruptio placenta, and I've even heard of cases where the actual umbilical cord split or tore, and which caused complete insanguination or bleeding out for the fetus, which means death. So again, fetal heart rate, 1 baseline, and then 1 full minute after is #1 priority. Then note the color, the time, of course, that it's ruptured, whether it's spontaneous or artificial, and any odor. Your book refers to temperatures are taken every 2 to 4 hours. We do not want it to get above 100.4 or 38 degrees, okay, centigrade. Some hospital protocols is that they take temperature every hour, and so you need to be aware that the guidelines are every 2 to 4, but it could be as close as every hour, especially if you go in and take that temperature of that mom and it's 99.2. Okay, we don't really consider that a temperature, right? Okay, but why would we wait 2 to 4 hours? Because it could literally spike to over 100 or 101 within 30 minutes to an hour. So at that point, definitely you would want to increase the frequency of those temperature checks. We want to continue to observe the color of the fluid and any odor. It is not uncommon for the fluid to be clear initially, which is good, but to change to meconium during the labor process. So again, noting that change at any point. And then any odor. If mom is starting to develop a fever, what you may identify is there's a different kind of odor to the fluid that is coming out of her uterus, and so we want to take note of that. Also, many times with mom, before we actually see that elevation in temperature, we may see an increase in heart rate, okay? So they may become tachycardic, and if you see that, you want to pay close attention, okay? What's going on? What's changing here, okay? And again, that every 2 to 4 hour guideline is not going to be sufficient. So again, nursing judgment is going to be very important. And then keeping mom clean and dry after an amniotomy. Again, that lining, that bag of waters is ruptured. We have a direct link to bacteria going into the vagina and to the uterus. And so by keeping the towels as dry as possible, keeping her clean down the perineal area is going to be very important. So let's talk a little bit about induction. Before any induction, it is important for the physician to determine that the baby is mature. We do not want to induce a premature baby if we can help it. Okay. Yes, there are those exceptions, and we're going to talk about those in a few minutes, but we need to be aware of those. Again, it needs to be done for medical reasons, not for our convenience, or just because my doctor's going out of town. Okay. We want to give that baby the best chance possible. So maturity can be confirmed by ultrasound or amniotic fluid analysis. We've talked about the LS ratio before. We'd like to see this at 2 to 1 in healthy pregnant women and diabetic moms. We'd like to see this 3 to 1. We also, physicians look at what we call a Bishop score. And I have a slide, a few slides later, but in your chapter on page 175, table 8-1, it discusses that. And this is just another measurement or way physicians can identify how mature the baby may be. Okay, again, it's not a definite. But induction is the actual initiation of labor before it actually begins on its own. Augmentation is a stimulation of contractions after labor has begun naturally. Okay, so you need to distinguish the two. And if you know vocabulary, okay, just looking at the words, you don't even have to think about anything else. Induction, induce, start up, augment, help along. Okay, and so try to remember those because that's important. So indications for labor induction are listed on this slide. Of course, gestational hypertension. Just because they have hypertension doesn't mean they're going to be induced. But if mom's health is being compromised, baby's health is starting to be compromised, this would be an indication for an induction. a ruptured membranes, maybe a spontaneous rupture of membranes without the onset of labor beginning. I identified infection in the uterus, medical problems in mom that may be worsening, fetal problems such as slow growth, past due, prolonged pregnancy, or incompatibility between fetal and maternal blood types. And then placental insufficiency. Last week we talked about late decelerations and what that's caused from. Again, you need to know what placental insufficiency is. So if you don't, you need to ask or read about it. Okay? But those would be definite indications for labor induction. And of course, unfortunately, fetal death. We're not going to put mom through a C-section if we don't have to, okay? Yes, labor is hard enough, induction is hard enough, but we would hate to put her through a surgical procedure and have her have to recover from that as well. But unfortunately, sometimes that happens too. Contraindications for a labor induction or augmentation, okay, would be a placenta previa. Okay, if you don't remember what that is, painless, vaginal, bright red bleeding. Or the symptoms. Those are the symptoms. You need to know what a placenta previa is if you do not remember. Umbilical cord prolapse. This is where the umbilical cord slips down in front of the baby, okay, baby's head, and then of course as baby descends through the pelvis, it's cutting off blood supply to the placenta and then ultimately to the fetus. One common cause of umbilical cord prolapse is after the rupture of membranes, whether it's artificially or spontaneous. If that baby's head is not engaged, which is what? Zero station, then they are at risk for this happening. That's why when mom calls in or comes in and she says her membranes are ruptured, that's why we want her to come into the hospital, so we can make sure fetus is okay and then there's not a cord prolapse. Abnormal fetal presentation, transverse lie or shoulder presentation, breech. Now you're going to probably say, well, I had so-and-so, I had a friend or a family that had a breech baby, or I had a breech baby and they delivered, and I delivered vaginally. And yes, it can happen, but we do not induce them, okay? That is not a situation where we would want to induce. If they don't go into natural labor on their own, they would probably end up with a C-section. High station of the fetus. If this baby has never dropped, okay, maybe she's 41, 42 weeks gestation, baby is -3 station, this is probably not the best indicator for an induction, okay? It probably tells us this baby's head is too big for mom's pelvis. Active herpes. Again, if mom has an active herpes infection in the birth canal, we do not want her to deliver vaginally. And so there's no reason for a labor induction. We're going to section her. She's going to have a C-section. And then, of course, abnormal size or structure of the mother's pelvis. And this can probably go along with the high station of the fetus. Kind of goes hand in hand many times. And then a previous classic cesarean incision. And we're going to talk about incisions for cesareans here in a little while, but a classic incision, or a classic cesarean incision, it's not the incision on the abdomen. It's the actual incision on the uterus, okay? And a classic incision is a vertical incision on the uterus, okay? This is one indicator or contraindication for a labor induction. Okay, so let's talk a little bit about cervical ripening. Prostaglandin, this can come in a gel, It can also come in like a suppository that is inserted into the vagina and up into the cervical area or right next to it. And this is typically the patient, the mom that has not gone into labor on her own. Maybe she's not effacing, maybe she's not dilating any. She's getting close to postterm, or maybe she's a gestational diabetic and we need to get her delivered, okay? So instead of starting with Pitocin, which if the cervix is not ready to be induced or ready for labor, and we've talked about that cervical readiness already, it is important to help that cervix get ready, okay? And this is a type of medication that we can use to help with that, okay? Also, laminaria is an alternative to cervical ripening. Actually, it's wrapped up real tight. It looks like there's different sizes, but it looks like it's actually not much wider than a very, I'm trying to think, maybe a nail, okay? But it is typically, and what it is seaweed, okay? And as it's put into the vagina and into the cervix, it actually starts swelling, okay? And that causes the ripening of the cervix and helps mom to dilate. This is typically not used for live births, okay? It's used for either missed abortions or miscarriages or stillborn deliveries. Another medication you've heard of maybe is Cytotec. I know you've heard of it because you had it on your medication list. With Cytotec or misoprostol, both of these can actually, how do I want to put it? And these are on page 175 as well, okay? Once you put these in, there's no retrieving the medication. It dissolves, okay, into the mucous membranes. And so one of the complications of the prostaglandin gel or the Cytotec is that they can develop hyperstimulation. We always want to get a fetal heart rate baseline. We want to get maternal vital signs. We want to have an IV or at least a HEP lock in place, okay, if hyperstimulation occurs. We would need to give IV tocolytics if necessary to stop the contractions. That's really the only way we can stop it. We can't retrieve it, the medication. We have to actually give something else that has additional side effects to stop it. Then oxytocin, of course, is for oxytocin or Pitocin. Oxytocin is a natural substance hormone that we women produce in our pituitary gland, okay? Pitocin is a synthetic version, is used for induction and augmentation. And it is the most commonly used method, okay? So the benefit of augmentation, you say, well, okay, you're only given the Pitocin because they've already started labor, okay? Why would you need it? Well, sometimes moms need a little help, okay? I joke and say sometimes just holding it under their nose helps get them into a contraction pattern that is going to help them continue to dilate effectively and efface their cervix. But typically if mom has already started and her cervix is starting to change, we have, of course, that cervical readiness, right? So many times it takes less Pitocin than an induction would. And also the uterus is much more sensitive to the drug when labor has already begun. So some non-pharmacologic methods. Walking, of course, is very, very important. We talked last week about the difference between true and false labor. You do need to review that, okay? Walking, if a mom is in false labor, it's not going to help it, okay? If they're in true labor, it's going to continue. The contractions will continue. So it actually can stimulate contractions. It also eases the pressure of the fetus on the mom's back. If she's having a lot of back labor, getting up, moving around, getting that baby's head and body off her back is going to help a whole lot. And then, of course, it adds gravity to the downward force of each contraction. Nipple stimulation, of course, as far as positioning, other positions, pelvic rock, anything that can, sitting on a bouncy ball. Of course, you need your coach, the mom's coach there, and maybe even the nurse to help keep her steady, because we don't want her rolling off and hitting her head. That wouldn't be good. Sitting in a chair, whatever helps her feel better is important. Okay, but walking is an excellent method, non-pharmacologic method. Nipple stimulation. This is either pulling or rolling of the nipples, gentle rubbing with a soft cloth, getting in a whirlpool, as long as her water is not broke, her back waters is not broken, or even using a breast pump, because that stimulates the oxytocin in the pituitary gland to be released, and therefore stimulating contractions. And I actually worked with a lady in San Antonio, and I'm sure there's others too, but she had not gone into labor on her own. She did not want Pitocin. She didn't want all this, these medications. But she also had a history of what we call precipitous deliveries, where once she went into labor, it went very fast. And so she came into the hospital, and her husband, in between rest periods, would use breast pump, nipple stimulation with a cloth, or pulling and rolling. She finally, after about, unfortunately, 6 hours, and they were exhausted, okay, she got into a good labor pattern, and she delivered 30 minutes later. So it was, we were glad that she was there. She didn't mind delivering in a hospital, but she didn't want all the other, equipment and personal care. So, complications of oxytocin, induction or augmentation. The most common are the fetal compromise and possible uterine rupture. Okay? When there's fetal compromise, what's happening, there is a decrease in the blood supply to the placenta during each contraction. That happens anyway, okay? But it's worse if there's not a relaxation period or a relaxation phase between the contractions. Okay. Most exchange of blood and nutrients from the placenta to the fetus is between the contractions, not during it. There's some, but not very much. When contractions are too long, too frequent, too intense, it puts mom at risk for uterine rupture, which we'll talk about further and later, okay? But with that uterine rupture, this is an emergency C-section. It majorly puts that fetus, or compromises that fetus immediately, and many times there's not a good outcome for either baby or mom. Other complications may include water intoxication. Pitocin actually inhibits fluid balances, and mom starts retaining a lot more fluid. We may see some of our moms on postpartum that are really swollen. Well, they're not swollen because they had preeclampsia or gestational hypertension, but they may have received a lot of fluids in labor. So again, when we're giving Pitocin, we want to use the smallest amount that is required to get mom into a good contraction pattern. Okay, and we want to continue to monitor baby, continue to monitor her. Her intake and output is so important. Monitoring her blood pressure and pulse is also very important. If we do start developing fetal compromise and the heart rate is dropping, she's having some late decelerations, or very unreassuring fetal monitor or fetal heart pattern, the Pitocin needs to be de-seed immediately. We need to increase her IV fluids. Basically, you'll see a nurse just flip up that, either take it out of the pump or flip open that clamp, and to give plenty of fluid. Position change, so maybe she's already on her left side. That's the best side, right? Well, we may flip her over to her right side. Okay, we're going to place an O2 face mask at 8 to 10 liters per minute, and we're going to notify the healthcare provider. We're going to have a tocolytic agent on hand in case we need to use it to slow down or stop the contractions and prepare for a cesarean section. Doesn't necessarily mean she may have it, because if we can correct the fetal, if we can turn this around, okay, we can, and we will, all right? Vital signs need to be, of course, based on institutional policy, but anytime someone is on Pitocin, their vital blood pressure needs to be, and pulse need to be monitored every 15 minutes, along with respirations, heart rate, and then, of course, temperature. If bag of waters is ruptured, every 2 to 4, and maybe as close as every hour. The chart on the Bishop score. Again, I think the chart in the book is a little better. I didn't mention this earlier, but a score of 6 or greater is considered, on the Bishop scoring system, is considered a mature fetus. Okay. So version is basically when the healthcare provider actually turns the baby, and you may think, why are they turning the baby? Well, some babies decide to not come down head first, right? They either want to come in with their shoulder or their butt or their foot. And so if we have the opportunity to rotate that baby to the correct presentation, then we will. Typically this is done, it can be done externally, and the picture shows how they do it here, and then your book goes into it a little bit more detail. Internal would be as mom is pushing, and let's say the baby's head is occiput posterior, and we want that baby, and we know that's not a favorable position, right? Okay, so the doctor may help as mom is pushing with each push, kind of hold that head, put their hand on the baby's head and hold it as it's trying to rotate to try to get it to go in the right direction. Risk, of course, we can put this mom into labor. So this is not going to be done until about 37, 38 weeks. We want her close to term. We're going to, again, get a baseline. We may even do a non-stress test or a biophysical profile to determine fetal status. We also need to make sure there's an adequate amount of amniotic fluid. We're going to have a tocolytic drug available to relax the smooth muscle and also to hopefully prevent mom from going into labor. And so the physician actually pushes, like the butt, if they're breech, the butt out of the pelvis while pushing the fetal head down in a clockwise or even a counterclockwise position. If mom is RH negative, and we're going to give mom RhoGAM, okay? Not likely that there would be maternal fetal blood exchange, but there could be. And so we would want to treat her with RhoGAM. And this is just a precaution, again, because we don't know what baby is. So here are some other contraindications. Again, mom's, cephalopelvic disproportion, okay? Uterine pelvic size and shape, abnormal placenta placement. So if you think about that, which one would that be? Possibly a low line or placenta previa. Exactly. A previous cesarean or a classic cesarean incision, okay, which is a vertical uterine incision, okay. Active herpes. Again, they're going to be sectioned. Why would we put them through this if they're going to have a C-section to begin with? And then we've already mentioned inadequate amniotic fluid or documented poor placental function. This can probably be determined on NST or a biophysical profile. Or maybe mom has been being managed and observed throughout her pregnancy for this abnormality. And so this would not be one that we would want to bring in to do a version. And then, of course, multi-fetal gestation. It's just too crowded. And one of the other risks is that they can get entangled with their umbilical cord. It can knot up. It can get around the neck a couple of times. And so all these risks are discussed with mom to make sure, and her partner, to make sure they understand. Afterwards, we're going to continue to monitor mom and baby. We're going to monitor to see if she goes into labor. We're going to monitor baby and make sure they tolerated it. And that's why you want all that baseline data ahead of time. We're monitoring for leakage of amniotic fluid. And before mom goes home, we want to review with her the warning signs of labor so she knows when to come back. Okay, episiotomies. Episiotomy is controlled surgical enlargement of the vaginal opening during birth, and a laceration is uncontrolled tear of the tissues that results in a jagged wound. Could result, let me put it that way. It doesn't always, okay? Lacerations are described in degrees. You have your first, second, third, and fourth. These are progressive, as you can see on here. First degree is the least concern. Many times, if it's that superficial, the physician doesn't even put a stitch in it. Second degree requires a stitch or two, depending again on the extent of it. But it involves the vaginal mucosa, the perineal, and some of the deeper tissues of the perineum. Third degree is the same as number 2, but it also involves the anal sphincter. And then the fourth extends through the anal sphincter and into the rectal mucosa. Episiotomies. It used to be felt that episiotomies were better than lacerations. And the kind that they used to do, and they still do occasionally, depending on where you're at or what's needed for that mom, is a midline, which is straight from the bottom portion of the introitus down towards the middle, okay, right down towards the anus, okay, and how much they cut is determined on how that physician feels they need to do it. Another type of episiotomy is a medial lateral episiotomy. It could be right or left, it doesn't matter, but again, that was felt to not extend into the rectum as much as the midline would. By the time I got into nursing, most folks were doing midlines. There were a few old guys that were still doing those medial laterals, and then now they rarely do episiotomies unless it's felt that it is necessary. And these do have to be repaired. Not all lacerations. The first degrees don't have to be. Repaired, but second, third, and fourth. In fact, a lot of times when we did episiotomies, women still had lacerations because what happened once that doctor cut, it allowed that tissue to tear even more. So you would hear midline with first degree tear, or midline with second, or midline with extension to fourth degree. And so episiotomies did not prevent lacerations necessarily in the mindset of many healthcare providers. Because through research, they have determined that if mom's going to tear, they're going to tear, okay, whether they have an episiotomy or not. So, some of the indications your book discusses: better control, yes or no. I mean, I think you could find different sides of that argument, okay? It provides a clean edge to sew up. Again, you'll find arguments on either side of the bench on that one. And then if there's adequate perineal massage and stretching exercises before labor, and also even during that pushing phase, some of you that have seen some vaginal deliveries, how that doctor or that nurse really massages that perineum and helps it thin out, then less opportunity or less chance of needing an episiotomy, and maybe even only a small laceration. Oh, before I go on to forceps delivery, and I'm not going to skip backwards because that's confusing, your nursing care for whether it's an episiotomy or a laceration, of course, is keeping the perineal area clean. We want to instruct mom to use a little spray bottle. We call it a peri bottle, but with some warm water. And every time she urinates or has a bowel movement, she needs to rinse that area and then pat dry, and then kind of let it air dry before she starts pulling up her pad and panties. For significant lacerations or a midline episiotomy, ice packs for up to at least 12 to 24 hours, up to 12 hours, I'm sorry. This helps reduce pain, bruising, swelling. So if you have a mom's describing of a lot of swelling, a lot of tenderness, stinging, and burning, an ice pack, pain medication may be warranted, but an ice pack may help just as well. Okay? After 12 to 24 hours, we're going to change over to warm, moist heat, sitz baths. And both of these can help increase blood supply to the tissues, to provide comfort, and to promote healing. And of course, analgesics are always there. But with analgesics, especially if we use opioids, we need to make sure mom is keeping her bowels soft and loose, especially with the 3rd or 4th degrees. We do not want her straining with a bowel movement. So fiber, fluids, stool softeners, ambulation. Okay, you need to remember that and know it. Okay, with forceps, there's several different types and kinds and styles, depending on the presentation of the baby, the size of the baby, and you're not expected to know that. Basically, forceps are curved blades, and they're actually placed around the baby's head without squeezing it or compressing it. The way they fit, and we call them salad tongs, the way they fit, they interlock, okay, above the baby's head, okay? And so therefore, when they interlock, they're not, and the doctor or the healthcare provider is pulling on the handle, it's not supposed to be compressing the face or the head. Now, if they're placed correctly, the healthcare provider is always checking to make sure their ear is not folded under, that it's not over an eyebrow or an eye, that is not pressing against a soft spot as best they can tell, and then only gentle pressure with pushing. You may have also heard when they used to use, or when forceps were used a whole lot, way back when, they would be, and you heard all the horror stories of what forceps did. These were being used when they were using what we call high forceps. And that was when the baby was not engaged in the pelvis, okay? Was above 0 station, maybe even a -1 or +1 station, but they were still high in the pelvis, and so therefore those forceps had to go much higher into the vagina. And yes, damage to the vaginal mucosa, bruising, hematomas, and damage and possible disfigurement of the baby's head. But it's basically there to actually provide some traction and rotation of the fetal head when mom is pushing. But again, it is only used when we can provide a safe delivery. Forceps can also be used with the cesarean section. For those that have been able to see a C-section already, sometimes that doctor has a hard time getting their hand around that baby's head. So sometimes they're used during a C-section. And so this is a picture of the forceps and how, it's around the head and neck, under the chin, okay, or right to the chin. And then as that head is starting to externally rotate and extend, okay, remember those cardinal movements, the doctor is going to position himself and how he is providing traction as that baby comes out. The next type of device that we have is called a vacuum extraction. Both forceps and vacuum extraction are used to assist with completing that second stage of labor, which of course is that pushing stage, right? Of course, we want to look out for mom and we want to look out for baby. If mom is getting very exhausted from pushing, it may help her, okay, to have that extra help from her healthcare provider. It is also necessary for both of these if mom has any cardiopulmonary conditions. Again, that way she doesn't have to push as hard, but again, we're guiding that baby through the pelvis. Or if baby's in distress, but it's faster to get it out with forceps or a vacuum than it is to set up for a C-section. That would be. So membranes, of course, have to be ruptured. They have to be fully dilated. Head needs to be engaged, 0 or lower, much lower. Your book mentions around +2 for optimal outcome for both mom and baby. And there are indications for both forceps and vacuum extraction. And so you can see how the vacuum extraction works and read about that also on page 180. Of course, we only use it for occiput presentation for vacuum extraction. We cannot use it for a breech. And again, these pictures are in your book on page 180, but it's like a little cup, and I will bring this to class tomorrow so y'all can see it. There's different ones today. They're a lot easier to use than they used to be. But again, it forms a section around the baby's head, and again, gentle traction with each push is applied to help the baby guide through the pelvis. Forceps and vacuum should never take a place of a cesarean section. Okay, so if the fetus is too high in the pelvis or too large, they need to have a C-section. You need to know what a hematoma is. Also, you know, with the bruising that can happen with the baby, this is going to cause some distress with mom and dad and other family members. So again, explaining that to them. And of course, you know, in extreme cases, they can have the cephalehematomas or intracranial hemorrhage. And so that is why this is only done by trained professionals. Before forceps or a vacuum is placed, the bladder of the mom must be emptied unless they're already catheterized. Nursing care, of course, if they have an episiotomy or a laceration, the typical care for that. Ice, cold packs, okay. For swelling, note for signs of vaginal hematomas or severe pain in the vaginal or rectal area. Assess the baby for bruising, lacerations, or abrasions and note those. Of course, we don't use cold packs on babies. Why? Cold stress, right? Possible injury to facial nerves, so we want to look at the asymmetry of the face. You know, when they cry, when they open their eyes, when they move around, okay? Typically this will resolve, but we want to make sure. The Chignon, C-H-I-G-N-O-N, this actually resolves on its own. Okay. Syrian birth, let's talk a little bit about that. Of course, it is the surgical delivery of a fetus through incisions in the mother's abdomen and tissue and uterus. In 2005, about 27 to 28% was our C-section rate in the United States. According to Healthy People, I believe this is in your book. Let me see. No, it's not. In 2010, the goal was to reduce this by 2015. The goal was to reduce this to 15% by 2010. There was an article I read a couple of years ago that actually showed the C-section rate to be closer to like 31 or a little over 31% in certain states such as Florida, where they were even over 50%. In some countries, C-sections are 100%. Contraindications are times when we really shouldn't be using cesarean for the first option of delivery. Would be, of course, stillbirth, premature infant that's too early to survive, or maternal clotting factors. If they have DIC, or if they're already in DIC, the chance of saving their life once we start cutting on them is going to be very slim. Okay. So indications for cesarean, of course, abnormal labor. Inability of the fetus. So we've talked about cephalopelvic disproportion. We've talked about where the fetal head is too big or won't fit through the mother's pelvis. Maternal conditions, gestational hypertension or diabetes. Okay, maybe mom has been induced or her labor has been augmented with those, but her conditions are worsening. With diabetes, many times the fetus is much bigger than an average fetus, so the baby may be too big to fit through mom's pelvis. Active maternal herpes virus, this is an indication. We've talked about that already. Previous surgery on the uterus, whether it's just surgery on the uterus for, polyps, endometriosis, fibroids, or a classic incision on the uterus, which is a vertical incision. Fetal compromise, okay, and placenta previa or abruptio placenta. Risk, of course, you want to review the risk of anesthesia that we talked about in Chapter 7. Respiratory complications, hemorrhage, blood clots, injury to urinary tract, the bladder, and the uterus. The uterus sits right on top of that bladder, and so it can get in the way, and that's one reason their moms are catheterized, so hopefully it keeps it empty. Delayed intestinal peristalsis, they develop an ileus or a bowel obstruction, and of course infection. We've made an open incision. They can be planned or unplanned or emergencies. Must always have an informed consent of the providers, what the risks are. Blood permits are also signed. Preoperative labs, of course, we're going to check for anemia, so we're going to do a complete blood count. We're going to monitor for infection, so a CBC, a complete blood count, where it looks at white cells, red cells, hemoglobin, hematocrit, platelets, and so forth. We may look at those as well. Clotting abnormalities, coagulation studies, make sure their coagulation factors are functional. Blood typing and screening for possible blood products. And then, of course, baseline vital signs on mom, fetal heart rate, and preoperative education. As surgery begins, IV antibiotics are given to prevent infection as a prophylaxis. Bicitra, which is a very sour, sweet liquid that moms many times drink before they go back for their surgery, and this neutralizes the acid in their stomach to minimize, hopefully, vomiting, and which can lead to aspiration of the stomach contents, and that can, of course, lead to pneumonia. Shave prep or clipping of the pubic hair, and, of course, an indwelling catheter. Output will be managed or monitored by anesthesia during surgery. And then, of course, afterwards, it's our responsibility. It is important to monitor mom's circulating blood volume throughout the surgery, so they're going to be monitoring that. Scrubs, we're going to scrub the abdomen. This can be done by the circulating nurse or the scrub tech. And of course, it has to, it has to be applied to the skin. It has to the scrub has to come in contact with the skin for a certain length of time. And I'm not going to get into how long it should be there or how long it needs to dry. That's going to depend on the product that is being used at the facility. Counting of all instruments, sponges, drainage cloths, needles, scalpel blades, all the above. And this is, of course, responsibility of your circulating nurse and your scrub technician. So the nurse in these situations have a lot of responsibility. He or she is responsible for maintaining her OR, maintaining sterile technique, obtaining supplies that are needed, have them ready ahead of time, but sometimes things happen and know where to grab when you need them in a hurry. And then, of course, be prepared and in caring for both mom and baby. In wonderful situations like at Baylor Scott and White, we always have a baby nurse and sometimes even NICU, and that's great. And then providing emotional support to both mom and her significant other. With the neonate, risk of cesarean, of course, maybe based on the bishop, maybe based on the LS ratio, they didn't realize they had a preterm infant. They should, but maybe not. So an inadvertent delivery of a preterm. Respiratory problems because of delayed absorption of lung fluid. And what happens, with a vaginal delivery is that baby comes through that vagina and that pelvis, a lot of the fluid that they have swallowed that's in their lungs pushes out. With a cesarean, they don't have that opportunity. And so a lot of times these babies are what we call wet babies. We have to suction them more. Their lungs may not, kind of be wet sounding when we listen to them. And, of course, that's why we want them to cry and scream and all that. And sometimes it just takes a little longer for their bodies to either get rid of it or to absorb it. And then, of course, just because knife blades and instruments are being used, there can be injury. So, you have two types of incisions. Okay, you have your skin incision. All right. This incision here is, of course, the low transverse incision, or what many of you know as fan and still. And you do need to know how to spell that correctly. Okay. Then you have your classical incision, which is more mid-abdomen, okay, and it's vertical, and that is a classical incision on the skin. And then you have your low vertical incision, and I don't know if you can tell from these pictures, and I believe they're in your book as well, maybe a little bit more descriptive in your book on page 182, but the lower vertical incision is just a little lower down on the abdomen, where the classic is up higher. Then you have your uterine incisions. Okay, uterine incision. You have a low transverse, and it's just like the transverse or the fan and still incision. Okay, this is not as likely to rupture during another vaginal delivery or during another labor. And in these situations, when it's low transverse skin and low transverse uterine incision, a VBAC may be possible. Okay. With a low vertical uterine incision, okay, there's minimal blood loss, okay, but it is more likely for the uterus to rupture during another labor or birth. Okay. And with the classic, which is rarely used, but it's important to always, if it is used, is that it's noted correctly on the operative report. So if that mom ever goes to another facility, she takes her records or can get her records, it is important for them to know that because definitely it is very likely for this to rupture. And you may not know it until it's too late. And remind me tomorrow to try to just demonstrate. I'm not going to rupture a uterus, but excuse me. But to kind of show on the board a little bit more, or show with, kind of demonstrating class with my hands of how the suture lines pull against each other and increase that risk of rupture. Okay? So help me remember that. Somebody write that down and tell me about it. Okay. So in the recovery room, we need to be doing vital signs every 10 to 15 minutes for the first hour to 2 hours, then every 30 minutes for an hour, and then every hour for 4 hours. And of course, exact timing depends on mom's condition, okay? Turning, coughing, deep breathing, splinting with a pillow over the incision. Again, these are healthy women, but they can get pneumonia just as easy as anybody, okay? Pain management can be IV, IM, or PCA. You do need to, there used to be a care plan. Let's see in your book. Yes, on page 186. Please review that and understand how your goal, your not nursing diagnosis, your nursing goals and interventions, and why you would do it that way. Monitor IV site and the rate. Make sure it's set correctly. Again, you're going to be doing your bubble maybe not all of it initially, because probably right after delivery we're not too worried about, the breast probably most likely would not have already developed lumps and bumps and redness, but definitely the uterus, the bladder, making sure that catheter is draining. We're not so much worried if she is having bowel sounds because she just had surgery so in the recovery room that first hour or so, it's not that important, but the uterus, the bladder, and the lochia. And then, of course, looking at her lower extremities for any development of blood clots. But we want to look at the firmness of the fundus, the height, where is it related to the umbilicus, midline or deviated, okay? We want to look, of course, at the dressing, the abdominal dressing. Is it clean, dry, and intact? Is there any drainage? All right? With a soaked abdominal dressing or any surgical dressing, let me put it that way, unless you have been instructed to take that dressing off, you do not, because what can happen is a clot can form, blood clot can form up underneath. If it's been bleeding through the incision, that blood is going to either absorb into the dressing, or it could, if it's significantly bleeding, it may have clotted underneath that incision. So what a clot does, just like that blood patch we talked about in Chapter 7, it seals over that area that's bleeding. Well, you pull that blood clot off and it could start bleeding again. So you measure how much drainage there is, okay? You document it and you notify the healthcare provider. Also the lochia, the quantity, the color, and the presence of clots. And again, keeping mom clean and dry as much as possible. And monitoring intake and output, not just of the IV fluids, but also her urine output. So remember we talked last week about the 4 Ps, power, passage, passenger, and psyche. The interruption of any of these can cause a dysfunctional labor. Okay? If you don't have adequate uterine contractions or adequate pushing, baby is not going to descend into the pelvis. If mom's pelvis is too small or baby is too big, it's not going to come through, and it can inhibit or cause dysfunctional labor. The passenger, which includes the fetus, amniotic fluid, membranes, and placenta, but primarily the fetus. If it's too large, if it's too large, it can't come through the pelvis. It can interrupt. And then if mom is scared, high anxiety, not cooperative, and I don't mean that in a negative or ugly way, but just can't follow through, can't follow instructions, can't relax, then that's going to inhibit her contractions and her labor progress. So, it's called dysfunctional labor, where mom's cervix does not continue to dilate or efface in an appropriate manner. Dystocia is difficult labor. Okay, so there's two different types of abnormal labor here, dysfunctional and dystocia. Factors that affect dysfunctional labors are advanced maternal age, obesity, overdistension of the uterus, where you have polyhydramnios or multiple fetuses. Again, it's like that rubber band that has been stretched so much it can't contract back. Okay, same kind of concept. Abnormal presentation. It does, that head being down. When the head is the presenting part, it actually helps contractions because it's actually applying the appropriate amount of pressure, hopefully against the cervix, to help it to dilate and efface. Okay, with the buttocks or a shoulder or a side of the fetus, it's not going to provide that adequate pressure. Cephalopelvic disproportion, where that head and that pelvis don't match. And then overstimulation of the uterus. That is when that mom is contracting, and she's contracting more than she needs to, okay? And that uterus gives out, just gets tired. Think about running a mile. If you haven't run it in a while, probably you're going to make it about 2 steps, okay? But if you overstimulate yourself, you're just going to give out over time. And then, of course, maternal fatigue, dehydration, and then fear. We've talked about that psyche, and that plays a big part here. And then lack of analgesic assistant. If we're not giving pain medication adequately, then that can play a big part of that dysfunctional labor. It kind of goes along with the fatigue and the fear component. Okay. Also with hypertonic, believe it or not, this occurs many times during the latent phase of labor. And remember, you need to review the different stages of labor and the different phases of labor. During the latent phase, are typically dilated from 1 to 4. Okay. It does not mean, though, even though it's like this, or the next slide where they're, okay, that they're not painful contractions, but these are not going to be productive, and they're not helping mom to dilate or efface, and so and the hypertonic ones are not as well. On page 187, there is a chart on hypertonic labor and hypotonic labor. I do want you to review that and know it. Treatment typically is, of course, if they're on Pitocin, we're going to stop or slow down the Pitocin, okay? Sometimes giving them some pain medication and helping them relax. If it doesn't, with the hypertonic contractions, we may give tocolytics such as breathine, also called terbutaline. Our nursing care, of course, is going to be comfort, position changes, helping mom and coach cope with the frustrations and reducing her anxiety. Before I talk about an ineffective maternal pushing, with hypotonic, this can many times be related to that over distension of the uterus, and you need to be thinking about what are those type of situations. Okay, treatment for hypotonic could be maybe performing an amniotomy, maybe augment her labor a little bit with Pitocin or nipple stimulation, maybe some IV fluids if she's dehydrated, or maybe even oral fluids if she's able to tolerate those. And again, moms are not, they're hurting, okay? And so providing emotional support, again, position changes, maybe getting them up and walking around upright positions. And again, there is I believe there's a great nursing care plan on page 188 you can review. So with ineffective maternal pushing, of course, first we need to make sure we properly coach mom on how to push correctly, okay? Helping the mom to identify contractions so she knows when to push, helping her to relax in between, help her to change positions and provide fluids to hydrate, and do our best in between contractions to preserve every ounce of energy that she has so that when that contraction comes, she has enough oomph to push with it. And so, you know, we can describe all day long how to push, and until a mom is in that situation, it's very hard for them to understand. So again, you know, those first couple of pushes may not be all that effective, and no big deal, okay? But practicing a few, helping mom understand, getting coach on board, you know, and other staff to support and help them through that, okay? If they have an epidural or a spinal, you know, they may not have any feeling, and it may eliminate their urge to push or feel anything in their bottom. So again, you know, maybe letting the epidural wear off just a little bit. Don't let them punch that button as often, so that some of that natural urge comes back. You know, it's kind of like pushing in the air. You know, pushing my hand straight ahead. I'm not pushing it up against anything. I don't feel anything. And if they don't feel anything, it's very hard to kind of focus on how to do it. And then, of course, if they're just overly exhausted. And that's why in labor it is so important to help them to breathe and help them to relax and provide that quiet environment so they can take those rest periods when they need to, so that when the time comes, they have the energy to do it. Okay, let's talk a little bit about some of the problems that can occur with the fetus. Fetal size is one. Okay. And this is actually, I believe, I'm looking. Well, let me go ahead. Fetal size is one of the complications that can occur, and you can see in these pictures the difference in sizes. A macrosomia, macro meaning large. So that's how you can break this word down. It means a large fetus, and that they weigh. It's a certain limit. They weigh more than 4,000 grams or 8.8 pounds. And with these macrosomic babies, and typically this is not unusual with your gestational diabetics, that are going to have difficulty getting through the birth canal. Okay, and large babies, because that uterus is stretched way too much, can contribute to a hypotonic labor dysfunction. Shoulder dystocia, again, usually occurs when a fetus is too large and they cannot rotate into that head down position or presentation. This is going to be an emergency. We do not want this mom to go into labor, because if her membranes rupture, what do you think she's at risk for? Rupture of prolapse cord. Fetal chest, of course, cannot expand, and the fetus needs to be able to breathe. And so if that shoulder gets stuck, or those shoulders get stuck, then this can lead to brachial plexus and those nerves, and it's just not a good situation. Okay. And then, of course, after delivery, a shoulder dystocia, they can be, delivered, and we're going to apply suprapubic pressure, the nurse is, when mom is pushing. But we want to assess them for lacerations on the mom. She is at higher risk for uterine atony and postpartum hemorrhage. And of course, we're going to monitor the infant for a possible fractured clavicle. So let's think for a second. What is the ideal position for the baby to be in for the delivery? From our conversations in previous lectures, it's where the arms and the legs are flexed and in a cephalic presentation, and preferably occiput anterior. So any abnormality or presentation or position may cause a difficult birth or difficult for the labor to progress. So just as mentioned with shoulder dystocia, with any abnormal position or presentation, of course, complications can occur. The fetus may not pass as easily through the pelvis. It can interfere, with labor, cord compression. It may require an external version prior to labor. And we know that versions are not always successful, This is a picture of a breech birth, and so you can see how, they can be delivered, but you can see how much difficulty it can be because, again, the butt is much softer than the scalp or the skull of the head, and so it's not putting as much pressure around or on the cervix, but it can. They can still dilate and they can still deliver, if they're not too big. But what you risk is down here, This part is the soft part of the body, right? Or softer part, especially the butt area. But, this may slide through without too much trouble. And then you pull the legs out, and then you get to the head. And this can actually clamp around the head, or the head may be too big. And that's just the part you just don't realize until it may be too late. So a common cause, or a position that we see in the fetus is when the position of the head is persistently occiput posterior, or LOP, ROP, LOT, transverse, or ROT. In most situations, the head will rotate either clockwise or counterclockwise to get into the position that is most favorable, but the duration of labor can be longer and it can be much harder on mom. And these may also require forceps delivery. So our nursing care, of course, we want to encourage various positions, to help with fetal rotation and descent, and hopefully to reduce discomfort. Sitting, kneeling, all fours, standing while leaning forward, pelvic rock, sideline squatting, especially during the second stage of labor, it opens that pelvis up more. Lunging by placing one foot in a chair with the foot and the knee pointed to the side. Well, again, this may not be really conducive for labor, without a lot of, maybe coach and nurse holding mom on either side. Multifetal pregnancies can cause dysfunctional labor because of there's overextension of the uterus, C-sections are not uncommon. It doesn't mean they all are C-sections, but they're not uncommon. And just because mom's, that overextension, they're going to have more issues with dysfunctional labors, poor contraction quality. And then it's not unusual for one fetus or one of the multi-fetuses to be in an abnormal presentation. Maybe the first one is head down and the next one's breech, okay? And so that plays a big part or can interfere with the labor and the delivery. Okay, I believe we're going to stop here. I believe I can get through everything else on Thursday, along with some of the other activities that we're going to be doing and review for the test for next week. Okie dokie. If you have any questions, write them down. Be prepared for tomorrow, okay? Thank you.